good afternoon, or good evening. Can you hear me? Good morning, this is David. Yes, absolutely. You're coming in loud and clear. This is David Cohen from the Mid-America Heart Institute here at TCT in Miami. We've got a big full room and a great panel here with us this morning. My co-moderator is David Williams from Boston. So please introduce yourself and the whole team. We're excited to see what you have to show us this morning.
Conference, he saw it. Actually, we didn't realize it. He said, say to yourself every morning, today is going to be a great day. He liked that very much. And here is on the board, if you can see, it is also written Happy Dasara. And all our Indian colleagues across there, especially many of us from our hospitals, then we wish them Happy Dasara. And we should be extremely thankful to the patient who, in spite of our festival here, cooperated and came for the procedure today. With this, I think if you're okay with it, we can go for the case details of the patient.
Yes, thank you. Thank you very much.
Here is a 69-year-old male patient, long-standing diabetic and hypertensive, with positive family history, with a history of recent inferior wall MI on importance of it. It is 73.6, HbA1c because the diabetic 7.2, hemoglobin is normal, lipids are normal on treatment, actually what is recommended. ECG showed inferior T inversion and echo had normal LV function with RWM. Carotid Doppler showed 20% stenosis in the right carotid pulse, carotid artery.
Yes, we can see it. Yes, we see it just fine.
Borderline stenosis, the proximal and the mid segment. Next. patient calculated came out 22. So it is upper limit of low risk. This background is not ready.
So let me just summarize the findings and make sure we're all in agreement.
Looks like there's a collateral, Dave, to a vessel.
Yeah, I think is the collateral to the distal circumflex? Is that what we were seeing?
Looks like LAD maybe.
Was it? I couldn't even tell. Very good. So your plan that you is going to be to treat the circumflex, which is the culprit lesion, and then to assess the LAD. Okay. So so it would be good if we could have a minute or two just to discuss with the panel. Does anybody think that's a crazy approach, or does everyone agree with that approach? Anybody want something different?
I'm just concerned about this vessel that's missing. It looks like there may have been a trifurcation of the left main as opposed to a bifurcation at one time, and there's an AV groove circumflex that's missing that you see filling from the right, and that in terms of ischemic burden, which is what you would like to relieve here, this patient may have a considerable amount of ischemia unless that totally occluded vessel is approached. If that's the proper interpretation, obviously we're looking at this quickly, but I'm wondering if that's not the case or not.
Would you be able to show us the first view of the circumflex again, just so we can appreciate that once more?
See,
there it is.
There's a collateral there too.
Yeah. So it's a distal circumflex. No, it's
or it's a.
That's very. I mean, let me ask one other question. So the other option that is on the table, we aren't going to watch it this morning, would be bypass surgery. Your patient is diabetic. He has what looks to be fairly significant LAD disease, although we'll see from the FFR. Would you consider that for such a patient? Is that an option in India? And how do you weigh that with this patient? Right. Thank you. I think you make a very reasonable case. Good. Well, why don't you?
If I might say, if he was in the.
Yes, please go ahead and get started. You have a lot to do.
If he was in the ischemia trial, we would have to fix that circumflex vessel. And I think his syntax score might change too if you really consider that a meaningful vessel. And it's interesting that the ischemia on the stress test was infralateral, which would fit with the distribution of that circumflex. Although there's another vessel with a lesion in that area too, but it could be both vessels. But certainly, I think that it's likely that he will remain ischemic.
Yeah, I think I think it's a very reasonable approach that the distal circumflex is just not that large. But does anybody think it's a very big vessel and very important to treat?
I don't think it's a big vessel, but according to the criteria for the synthesis score, it should be calculated for this vessel, which is more than 1.5 and more than 50%.
So it should count in the score.
And then you will shift your synthesis score.
I mean, he'll still have some ischemia if it's not treated, but it's not going to be a huge amount, and I think probably not going to contribute prognostically that much.
Yeah. So tell us what you're doing. We're just discussing amongst ourselves while you work. And is your axis femoral or radial? I can't tell.
Dave, while he works there, just a real quick question. This is the largest LAD I've seen in a long time. So you have a negative cardiolite, and Dean Kyriakis has made this point time and time again. When you have a negative cardiolite, how do you interpret the FFR data in such a large vessel? How many patients in FAME 1 and FAME 2 had a positive nuclear scan? And I think Dean has made this point. Is there any clarity? How would you two look at a positive FFR and a negative cardiolite in an LAD? Large?
My understanding that the FFR is independent of vessel size unless you're quite distal. So I would think the FFR would be a value.
Yeah, I guess my concern would be balanced ischemia and the inability to detect the LAD. I think it would be good, but we can wait a little bit because I think we want to take a vote on the panel as to whether we guess the LAD is significant or not. I think that will be good to do before they do the pressure wire, if that's what they're going to do.
I think it's a good decision to do the pressure wire in that case also. I mean, I think that it's a big area at risk. There's a diagonal branch there. You would not want to be wrong on that. On the other hand, you wouldn't want to do it unnecessarily. So
Right.
I think it's very wise. I think it's very appropriate to do an FFR in that instance.
So you've dilated now. Was that a 2 millimeter diameter balloon that you used? Very good. What kind of drug-eluting stent will you choose for this diabetic patient? Terrific. So let me ask the panel: does anybody feel there's a better stent? Resolute integrity is fine. Should we use anything else preferentially, or is this a good choice? Everybody says it's a good choice. Go ahead, please.
Stent in both these views before we go on to fix it.
And the length of the stent that was picked is what?
We have taken 2.75 and 26.
Yeah, 26. 26.
Funnily, resolute.
Seems like a very reasonable choice. It should be able to cover the whole lesion.
Yeah. So previously we used to have 24 and 30 with Endeavor Resolute. Now probably integrity they've had alternative size of 22. I think that's okay here. Millimeter back. Okay. Okay, come to epicaudal.
Okay.
I think that should be okay. You are going up here.
That looks perfect.
We went up to 12. Just to see whether LED is okay. We went up to 12 atmospheres here. Negative.
It looks good. Just clear of the left main. Excellent.
Cine.
I think the proximal end and distal end both look alright. And it is appropriate.
What does the panel think about post-dilation? I mean, angiographically it looks pretty good, 12 atmospheres, maybe less than what some might think should be standard.
I would use non-compliant dilation.
In the center?
Rio non-compliant balloon.
18 atmospheres.
Some people on the panel think maybe you should post-dilate. Do you intend to post-dilate, or
We are trying to do it with
are you happy?
2.75 balloon in the center, in the mid segment, because the stent we didn't go too much high pressure to avoid dissections in the edge. In the center point where there looks some residual thing, now we have taken Voyager NC 2.75 to 12, and we'll go up to high pressures here. So we are agreeing with the panel's discussion to opinion, and we are we're proceeding with dilatation.
The panel agree that people should routinely go to say 18 atmospheres or not? Would anybody stop at this point? And
I wouldn't. You know, I think it partly depends on the stent size you pick. If you pick a 2.5 here instead of a 2.75, then I think you go to 18 atmospheres. If you're picking on the upper end of the range you want to work on, I might not go as high, but I almost never go below 14. And I do multiple inflations because I think most of the stent deployment balloons get a little bit more growth on the second inflation because they have some compliance. And but that's, there are a lot of ways to individualize it. But I do think that
do proximal
if you do IVUS on many of these and you've only gone to 10 or 12, they're very rarely symmetrically expanded.
So it's probably fair to say that in most you would go to at least 18, right? Is that correct?
Yeah, because especially this later generation stents, you need to be...
MI, it's a different.
Yes.
We try to avoid high pressure, but vision, definitely we should use higher pressure, non-compliant balloons. But if you use, I will very often see under-expanded stents. What is also important is time of inflation, because if you inflate the balloon for 60 seconds, you get much better expansion with the same inflation pressure than if you use very short inflation like
And the issue with acute MI is low, among others, that would be something you could, whether that's a humoral substance you're squeezing out of thrombus that goes downstream and causes vasoconstriction, but you're right, I think that's an important characteristic is the MI, the STEMI patient, the primary PCI is different than the other. You can always go back later on if he gets restenosis.
So that looks fantastic. Are you happy with your result there?
Yeah, we'll take a final picture before we decide. Okay. I think that after post-dilatation it looks good. With this, I think we can come out of the eleocaudal. Take one eleocaudal picture also.
I agree. Everything looks wonderful. That's
okay. So
couldn't ask for a better result in the OM.
So now we go to proceed with FFR to LAD. For the sake of time, we have already calibrated the
introducer.
FFR wire.
So let's stop here just for a minute, if we could.
Yeah.
To discuss a few things about your FFR. So can you tell us what system do you use for FFR? Do you have a preference?
Yeah, we have the radii
Manufacturer.
analyzer now, which is being marketed by St. Jude's in our country, and other system which is available is a Volcano that is interposed with IVUS as well as thing. Can you project?
Right. So that.
So now,
will you be using intravenous adenosine, intracoronary adenosine?
Yeah, we generally follow.
What stimulus for hyperemia will you be using?
Intracoronary bolus injections we use. We give up to 150 micrograms of thing. This, if you can see here, can you project here?
So can we?
So this is a transducer tip. I think many of you are already aware. The sensor,
we can see.
the sensor is about. You see, the sensor is about at the end of the my pointing needle. It's about 3 centimeters from the tip. So what we need to be careful is the sensor, the pressure we need to see is from that sensor, not at the tip of the wire. We need to handle this FFR wire also a little more carefully because it is slightly more stiffer than the regular angioplasty wire. Though it is 014, the tip is slightly more stiffer.
So if you could wait before you put it down, because I want to pull the panel about the significance of the LAD. If we can make some guesses among the panel.
I'll make.
So you're going to place the wire down into the mid or distal LAD.
Yeah.
So let's vote. So how many? We'll give three levels. We'll say more than 0.8, 0.7 to 0.8, or less than 0.7 for this LAD among the panel. So how many people think it's going to be more than 0.8 for the FFR? Anyone? No one thinks that. How about 0.7 to 0.8? Almost everybody. I think it's going to be less than 0.7. I think it's going to be, but let's see what you get.
You want to talk, Dave, a little bit about IC versus IV adenosine? That the yield, like if you use IC, it's okay if it's positive, it's abnormal, but if it's normal, you could potentially find some patients that would be less than, would have a low FFR if you gave it IV.
You gave it IV. I think it's, well, let's pull the panel here. So how many of you in your center use, does everybody use FFR? Anybody not use FFR? Everybody uses FFR. How many do IV? Everybody does IV, so nobody on this panel does IC.
That statement was very important. That you can first start with a coronary injection, and if you have positive FFR, there is no need to use fusions, which is of course also the cost issue.
That's for sure. Well, you can often get, in my experience, just the hyperemia from the contrast. If it's a very significant lesion, can often give you the answer if it's positive.
However, what is important for patients like this, quite diffuse disease, that the ostium of LAD to the mid part, long lesion, and if we want to guide the procedure with SFR, then we will probably do the special pullback.
Lesion.
That situation is a much more stable situation to use intravenous in continuous infusion.
Yes, that's a great point, and I do think that's, I mean, certainly for me, and I suspect many of the other panelists, is one of the main advantages of the IV is you do have the ability to pull back, and you're absolutely correct. This is quite a diffusely diseased proximal LAD, so it will be interesting to try to understand where the assuming it's ischemic, where it's coming from.
Yeah, I think.
Great. So just let us know what you're doing.
Yeah, we have just put the FFR wire in the proximal portion and equalized the FFR tracing. Now we are crossing with the FFR wire, and then we will give intracoronary adenosine. Cranium. Actually, very important. It is very important to equalize the pressure tracing very correctly, because
it's possible to.
If you are not equalized it properly, then you could get fallacious values. So it's very important to equalize.
And you need to have the insertion tool out of the TUI bores, and you need to have the guide out of the proximal left corner.
I think now it has crossed beyond that lesion of importance. Probably we can check FFR here.
So if
Dave's always right.
I don't know. Yeah, for that.
Baseline inside.
Yeah, so if we could see the hemodynamic screen from the analyzer, that would be very good. Great.
Just slightly
So
turn
is that
this.
with or without adenosine?
No, this is the basal value. We're just giving some NTG.
That's the resting gradient? Okay. All right. I win.
Man, Dave's always right.
Yeah, for it. Are you going to give adenosine or you don't bother?
Yeah, once the baseline itself is that value.
You want to make sure pullback that you haven't changed things either. You know that the zero is still zero. 100%.
But that's I mean, this is, you can see just by the pattern of the tracing that it's ventricularized. The distal pattern. It's clearly not an artifact. It's a real.
Right.
And we did equalize before we went in.
It's quite important. So I would use intravenous infusion, then do the pullback and try to find gradient on different levels of the vessel, then decide which to first.
212.
We want to go to CI.
So is that with adenosine, the 0.59 that I'm seeing right there?
We just gave nitroglycerin to basal, then that's the result after the nitroglycerin. I don't think we need to give adenosine because
nitroglycerin.
The basal itself with nitroglycerin is 0.59. What the panel feel? Generally, if a baseline value itself comes all right, so we generally don't do further.
The panel agrees with it.
Okay, so now we proceed with the tackling of LAD.
I think what people are interested in is some sort of a pullback, if you could.
So you need.
I'm not sure how often that's helpful. If you have multiple discrete lesions, I think it can help you with that treatment. But if you've got a diffuse segment, I almost always have to stent the whole segment because the edges don't otherwise look good.
So you want to say
can
that?
You put up the LAD angiogram again so we can see.
LAD. We are showing you the angiogram again.
Next.
When you say to pull the guide back, you mean to disengage totally from the left main?
That's correct.
Yeah, I think that.
Just a couple of millimeters.
You really can get a pseudo lesion very easily.
So I guess the question looking at this angiogram is, so are you planning to treat all the way past that second diagonal?
Yeah, we feel out of the things which are there.
I think
yeah, go ahead.
I was thinking that in this case, as it's been proposed, a pullback using intravenous adenosine will be very important because in this long lesion really there's like two areas where your eye is.
Okay, we'll do that for you if you want.
One conservative approach will be stay proximal part and then do the FFR again. And to do that, I would like to see in the pullback, I would like to see a jump. And I will target that to see if I'm lucky and I can avoid treating the whole vessel.
I mean, I would agree with that. That's what we would probably do also. We're just discussing how to sort out really that second lesion, because I mean, I do see two lesions here. I see the long proximal LAD lesion, and then I see a more discrete lesion right beyond the second diagonal branch that I'm a little curious about. And now it's tricky because when you have the two lesions in series, they interact, and you can't easily tease them apart. And so one way to do it would be just stent the whole proximal portion. We know that's important, and then test to see if the residual in the distal is significant. But, so let us know what your strategy or your thinking is about how much to stent based on your findings.
Actually, we did think of like this before. Now I pulled the FFR wire back, and now the sensor is in the mid segment before that lesion. Can you see that? I'll show you. We'll take a picture.
Yes, we can see it.
Now the sensor, though tip of the wire has crossed the lesion, but the sensor is proximal to
Okay.
the
Tip of the wire is crossed the lesion.
That's without adenosine.
So it's still very significant, even just the proximal lesion, even taking into account that there's a distal lesion that impairs the flow reserve. So clearly the proximal lesion needs to be treated. So again, I think there's a suggestion here from the panel to go ahead and treat the proximal disease, and then test to see whether the mid lesion also would need to be treated afterwards. Does anybody think that's a crazy idea, or everybody kind of likes that strategy?
Well, I'm concerned about that lesion by the diagonal and whether the diagonal is involved. And if you treat proximally, you may limit your access. It may be tougher to deliver hardware.
That's the risk, yeah.
Particularly if you had to put two of something in.
Well, anyways, we're just having an academic discussion here. You let us know what you're thinking and what you're going to do.
I mean, from a practical standpoint, I think, or technical standpoint, I think Dave's correct. I want to make sure I don't need to do the diagonal before I put a proximal stent in. So if you think there's any likelihood you're going to do the area right after the diagonal, which seemed to contribute a fair amount to the
gradient,
the non-adenosine gradient, then I would like to know the diagonal doesn't need additional proximal lesions later.
No, I think these are all, all reasonable concern. Are you speaking about the first or the second diagonal as the one?
The large diagonal.
The large one.
It's the second lesion.
Okay.
And there's additional disease between the proximal and the
balloon
lesion right after the diagonal that is going to be hard to.
So let us.
We would have taken
Tell
that.
us, please, what you're planning to do now.
Yeah, we would have taken that way, but only problem here is tortuosity and the long segment disease. If you put the proximal stent, the tracking and the approaching the diagonal and all that could be difficult. So anyway, the distal lesion looks more tighter out of the two. We thought we could cover up, predilate serially, and then probably cover up from the mid segment back. Now we have taken the same balloon to predilate.
So you're going to go with stenting the most of the LAD.
Yeah, because both segments it came important. DCC segment looks like after the diaphragm, the LAD looks normal.
It's possible to do FFR in a side branch too.
Yeah.
Sure. It's just, the challenge here, of course, is interpreting the FFR into the branches beyond other stenoses. The FFR integrates the entire physiology of the involved vessel, and so it is hard to isolate this, the individual stenosis.
From a purist standpoint, treating the proximal lesion and then remeasuring the distal gives you the best assessment of its contribution. But from a technical, practical standpoint, that gets complicated.
Yeah, no, I absolutely agree, and I hear what you're saying.
How about a wire in the diagonal? Anybody interested in that?
This should be done probably to protect those side branches.
It's a major diagonal.
Both third and second diagonal.
So some people here think they would put a second wire in the large diagonal at least.
Yeah, we can do that.
Have you considered that?
Yeah, inadvertently actually FFR wire.
Whatever your preference is. I think I saw that there was maybe a little slow flow in the first diagonal now. And what size balloon is that? Is that a 2 millimeter balloon?
Yeah, the same old balloon which we took before.
Same balloon.
Yeah.
Good.
So it looks a little smaller size for that, but rather than opening another balloon, we thought we can do it off. We'll give nitrogen and take picture and then decide about the stent.
Would you like to treat LAD with one long stent or just two stents?
One long stent won't be enough to cover the entire extent.
Do you have a stent long enough to treat? I don't know.
Yeah, whatever is the longest available, we can take.
I don't even know if a 38 would.
Even 38 could become. Now, if you see that the diagonal looks all right, I think unless
2.75.
Your bias to treat and dilate the diagonal ostium, I think you can proceed
2.75.
With stenting across the diagonal. Which is after dilatation, the diagonal flow seems to be all right. There is no slow flow. So I think to keep it more simpler, probably we can. I agree. If you have osteal disease of the diagonal, then probably we would tend to work on
2.75, 38.
I think we may be able to get away by stenting it across the diagonal. But if you want to be more careful, you can wire the diagonal also.
So you're thinking just.
We'll take a 2.75, 32.
Okay.
Yeah,
so it is.
Yeah, we are tending to take the longest stent available. Which one? 38 is it?
Doctor, can you speak slightly louder?
Yeah.
So probably not protect the diagonal with wire.
I don't know. I mean, so how many? So we'll pull the panel. So at this point, we're planning to stent most of the LAD. So how many people would put a wire into one or both of those diagonals?
Wire.
Yeah. So a lot of the panel would, and the first diagonal, which looks tighter, or the second diagonal?
Second.
You would put two wires, one in each.
Two wires.
Just
to protect.
Just to protect. You would not post dilate. Anybody who wants to pre-dilate the diagonals?
No. Two wires, but not pre-dilation. I missed the diameter you used for the pre-dilatation because
2 millimeters.
It's pretty small if you want to deliver a long stent. I have some concern about the calcifications there. If you saw the deployment of the 2.0 balloon, there was true bending even of the short balloons. I'm concerned whether you prepped the lesion well.
Yeah, no, I think that is a bit of a concern.
Then two wires might be a problem.
Yeah. So there certainly is some calcification in that mid and proximal LAD.
Yeah, I think
go ahead. We're just
I think as the diagonal ostium is free, whatever the longest stent available in the lab we are taking, usually we tend to use similar stents, but 38 is the longest stent available in the Promus Element Plus platform. So we are taking that to do it. I would agree that probably Endeavour Resolute, if it was there, 38 would have been better. So because the ostium is free from disease, we are going taking a chance and doing
38 Promus elements as long as we have to.
What is the length of your stent?
I think if you're going to put wires in to protect the branches, 3 wires in a 6-inch guide plus a long stent is an awful lot. But I think the first diagonal would be the hardest to get back into if it closed. So if I was going to do one of the diagonals, I would probably do the first one.
Yep.
Because I think you can get back into the second one if it gets compromised.
I would tend to agree with that as well. As the first diagonal has a more unfavorable angle. It also looks to my eye like it has a little bit of a tighter stenosis. But let's see if this stent will go.
Yeah, the angle of the origin of the first angle is closer to 90 degrees, and I think that statistically is less likely to close off than a narrow angle side branch. So
it's a ring.
2.5.
Which one's more likely to close and which one's more difficult to wire if it does.
And you want to make sure that the proximal end of the distal stent is not on that diagonal because you don't want to overlap at that point. So that'd be a concern. You could never get back in.
Yeah.
I think you're
facing some difficulty as expressed before.
It might be tough to deliver the stent, and I guess it was.
And we are taking, because it's a long stent too, we are taking a 2.5 balloon and dilating at that point in the mid segment where there is a resistance.
Yeah, that's seems, I think we get so spoiled by the stents we have now that we always think we can deliver them. If we can put a balloon, we can get a stent, but not always.
That was the precise...
Coming back to the side branch issue, you might consider the fact that your stent is too short to cover the full lesion at least. So in this case, you could consider putting in a second wire in the second diagonal, do a short stent, make sure that you have your end place where you do not overlap with the second one, and measure the remaining vessel to treat, and put the second wire in the first diagonal, so you avoid having 3 wires in.
Yeah, no, I think, there are a number of considerations in this lesion. One of the things we're discussing is trying to make sure that you don't end up overlapping where one of those branch points comes off, because that could complicate rewiring needed to, and that's...
there's enough calcium in the mid-vessel that it looks like stent may be already there.
The other thing is that the stent that's distal to the second diagonal, the diameter of that may be substantially less than if you did IVUS. That proximal segment is probably pretty big, because look at all the branches that come off.
No, the distal vessel looks almost like a 3-0 vessel,
right.
Way down.
I bet you the proximal vessel is actually more like 4-0, but diffusely diseased. So you could make a case for stenting just beyond the diagonal, the second diagonal, with say a 3-0 or 275, and then putting a larger stent, a 3-0 or a 3-5 up front, have it overlap distal to the second diagonal, so there's no overlap in the area of the diagonal. And then you could have a big, a nice, IVUS would help sort that out. Not that we should do it, but I think you would, it's likely, because that second diagonal is pretty big.
Yep.
And so there's got to be, the vessel proximal has to be a lot bigger than the vessel distal.
I completely agree. This is a very good suggestion, and it would be easier to do this procedure with 2 shorter stents than just one long such. Short and calcified vessel.
And you won't make it with a 3/8 anyway.
Yeah, I think it's...
you may have to stent the proximal
keep the
just
overlap.
because that area is a feeding flow.
Yeah, I think, the most difficult thing here is figuring out what the length of the whole segment is that we're treating. And this is a case where, if you had and were comfortable using one of these marker wires or something like that, it might really help, because I don't know how long, how much stent length are we going to end up with here? Are we going to end up with 50 millimeters of stent? Something like that probably, huh?
I think I'm wondering at this point, this procedure is absolutely based on the FFR value, but to get the FFR value is below the second diagonal branch is less than 0.7, but in the upper portion there was some step up to 0.9. I'm wondering if all of the panelists totally agree the long stent is the cover the whole LED segment based on FFR value. In our practice, we usually if there was some step up the pressure, we just put the distal stent and then recheck the FFR and then decide what's going on in the next procedure. I'm wondering if
so you're suggesting stent to distal with a shorter stent, and then,
right.
Then test. I think it's we've kind of we would like to be able to separate out the contributions of those 2 lesions. I think most people seem to believe that the proximal lesion is contributing substantially, but I think it's a valid point.
Of it.
It's okay.
So you certainly have made your life easier by preparing the vessel a little better, and that's good.
You sure don't want to dilate that proximal end with your stent. Get a action there.
What stent to do?
You don't want to be short the distal end here.
No, because then you have to go through it again.
Exactly right.
I think we're okay, but although there's still some disease, I think even beyond where the stent ends.
We'll find out.
How much pressure there?
Yeah.
12 atmospheres?
12.
14.
Touch 14.
12 again.
Yeah, we just touched 14 once, but the deflate.
The fact that balloon keeps that curve makes you think that vessel is calcified. That balloon is not straightening out that vessel.
Yeah.
So that is a calcified. Probably deep calcium.
You'll be able to
As you keep watching here, when you are withdrawing the balloon
Certainly.
back, you need to be more careful with the guide tip. They tend to get sucked in. So I was making sure that too much of the guide doesn't enter into the vessel, because it could produce proximal dissection when you are pulling the balloons back. So I think fortunately both the diagonals are patent.
So I think we have I'm just keeping track of the time here.
Yeah, that's why we are trying to work on when you are discussing.
Good.
Yeah.
We have about 10 minutes to go, I think. So
Cardell?
let's see how you What's covered? Good.
Distal entrance was on
A little something at the distal edge.
Yeah. It could be
Yeah, I
spasm.
mean, there's definitely some mild disease beyond the stent.
C minus 320. C minus.
Could be. I think there was some plaque there even before. I think I mean, it was just a very long lesion.
There's plaque everywhere,
Some accordion.
even the 3O area.
Yep.
Scene
Now the good news is you've taken this long stent back proximal to the first diagonal, so you don't have to
Yeah. So
double
now
layer any of the diagonal origins.
Everybody stayed home. Well, everybody's present counted.
Yeah. Yep.
now we need to
Good.
take appropriate size
Would-
stent and then fix up the proximal portion
28.
from the ostium.
28. 24.
And then do you plan to post dilate after you stent the proximal?
Yeah, probably the overlapping.
28 balloon is there. 26
There's
balloon.
already there is some step up at the distal edge. So if you want, we can do post dilatation within the stent. But I think after we
We have
position
to
the
watch
stent,
time here, but the other thing that needs to be watched is
Yeah.
Dilo.
we had the plan
I
after
don't think
finishing.
anybody anticipated it's going to turn into,
What is
you know,
it?
if one of those dyads gone on down, you had to salvage it. It can really be a mess.
Yeah, I mean, my sense is they've been pretty efficient so far, but we do have to be respectful and not ask for too many angiograms, just because we're interested in what we see. So how long does everybody think we need to count to go from the left main down to the other stent? At 18 or so? What?
Because it's very
How
important
long
to
of a
take
stent
an
do you think you
appropriate
will
size
need?
stent, we thought we could check it to the balloon.
24.
Can
So
you-
you're measuring using the balloon markers.
Yeah.
What length of balloon is that?
Yeah, this was 26 balloon, the one which we used in Ramus. So I think this looks slightly long. We are going with a 24 balloon. Is that okay, or 24 stent?
Length.
24 stent? Would you?
Yeah, this is a 26 balloon.
I guess my concern about a 24 stent is you're going to end up overlapping that first diagonal, I think.
Okay, we'll go ahead with a
Does anybody
18.
want to use anything shorter than a 24?
20?
What would you use, Carl?
I think I would use an 18. You're trapped
Do
18 to
18
20, I think.
You don't want to be in the left main on one side.
18
I
balloon.
wouldn't be in the
Yes,
prefer not to be in the
We'll
left
take
main. The
18.
other side, you don't want to be too much overlap, because otherwise you overlap at the side of the side.
Yeah, I think
20 would be fine.
Yeah, I think an 18 or a 20 would be okay. So, but
Thomas element 18.
let us know what you think.
I don't know
Okay.
whether the panel
28.
wants to go from the left main into the LAD or stay in the LAD.
Yeah,
I would be tempted to stay within the LAD and not go from the left main to the LAD.
Yeah, we have a 20,
Yeah,
20
but the
stent.
disease comes back very close to the origin.
Vision is just involving the ostium of LAD, so in this case, probably it would be done much easier with IBUS guidance on GFX.
IBUS guidance for determining length or for...
For determining the length, the extent of the disease, and also to check what happened in the left main itself.
there certainly can be some value there. So we have about 5 minutes more, I think. So why don't we let you work? You go ahead to...
Okay.
We're very curious
I think,
to see how this
this
finishes up.
This is looking bigger, so we have taken
To the length, I
318.
think you'd want to
Our
make
plan
sure
is
you're long enough
just
to
to
have to put a third stent in.
start
Because
from
you're
the
going to be
ostium.
positioning the stent based on the proximal marker.
Yeah.
And like this view, you're going to be you're going to...
Go ahead. We didn't hear what you just said.
Yeah, because that was looking longer, we have taken 18 or 20 mm stent, 320. We want to position it from the ostium to within the stent. Hopefully we should not come across the diagonal ostium. We should be just overlapping.
So this is a 30 by 20 Chromis element?
Yeah. Come into the epicorder.
The length will be fine.
Okay.
Yeah.
LAO caudal view looks like a good view to
Yeah, we'll again check in that also.
That looks pretty good there.
The image was not very clear because of the caudal. I just wanted to check in.
Yeah, I think this is a,
Yeah, we'll again check in LAO caudal.
Yeah, I think but the caudal also shows nicely where the diagonal comes off.
Yeah.
I think
LAO caudal.
Yeah. We are just ending
Yep.
a shot of it, and we are covered to final test. Okay, go ahead. The LCX is also feeling
So I think
well.
it was a good call not to use the longer stent. I think that would have been smart.
Or a shorter stent.
Yeah, okay. Either one.
Better call.
Yeah.
Okay. And we'll just overlap segment again. I will do it with the same balloon. Okay. Okay. Leaflet. The distal was 2.75. The proximal is 3. I think. Cine.
So we have about 3 minutes left of transmission time. So let's make sure we
I think this
plan for that.
I think this view now the proximal portion everybody should be happy. Both the diagonals are all right.
Take one apical.
Terrific.
No, it looks really good.
Okay, so we just for
Definitely
academic.
some pinching of the origin of that first diagonal, but it's got normal flow.
Minus. Yeah, but as you understand, as the flow is maintained, I think we should not
Can you
be.
check the eyebrows?
Yeah. Now we'll just check FFR once post, so that if it comes negative, now you will have more confidence on FFR. What does the panel feel about it?
Yeah, I think that would be great. I think that would be. Everybody like the idea of a final FFR here to make sure that distal lesion is not still significant?
You don't take a non-compliant balloon to finish the procedure, no? On the lady, proximal lady. First
calcify.
Yes, so it's calcified and.
Post-dilation.
Yeah, I think it's. I mean, certainly it's possible that. I would agree.
Yeah, one more before.
The live was here. There will be plenty of under-expansion decalcification events. But the price you have to pay is that you can improve the diagonal. So it's a difficult situation here.
No perfect solution. No. Thank you.
Yeah.
Okay, go ahead.
I think we'll go ahead and measure the FFR. Other thing which I wanted to mention because of paucity of time, probably the distal RCA lesion we wanted to because it is a smaller vessel, 2 mm, 2.5. We wanted to dilate with a Magic Touch sirolimus eluting balloon, which is just launched by one of our Indian company, and then probably it has nanoparticles on the balloon with a good drug delivery system with studies done by Renu Virmani and the group. Because of lack of time, we are not able to show, but I think you would agree that once we have fixed up the left lesions, now we will tackle the right artery, and if required, probably after a drug-eluting balloon, we would place a normal stent. We started 5-10 minutes behind
that sounds like
okay, I think this.
Yeah, no, I'm sorry. I apologize for that.
Yeah. Then we thank for the.
How was your FFR?
Yeah. Because we could break in before we finish the FFR. I thought I would just mention once. So we will again check FFR. Probably, hopefully, it will be coming to normal now, and then we'll also give NTG and address the distal LAD, how it does look, and most probably it is a spasm. It should be okay. Then we will work on the right and then close down the case. Is that okay?
Well, that's terrific. I think we want to really thank you for an excellent demonstration of a very complex PCI procedure, done very beautifully. Obviously, you still have a bit more work to go, but we really appreciate your spending the evening in India with us this morning and showing us your expertise and how you tackle these tough lesions.
Yeah, we too enjoyed it, and thanks for the opportunity. We need to work on further in the structural heart disease session later. We thank our entire
All right,
team
we will
members.
see you later then. Thank you again.
Thank you very much. Bye bye. Bye. Thank you.